across Canada, we find healthcare in crisis. But one province, Alberta, is actually making some very bold reform changes to try to change the system to bring it closer to European models. Well, today we're sitting down with Premier Danielle Smith to have a long form discussion about health reform and discuss some of the major changes that are happening in her province. Thank you, Premier, for taking a few minutes to chat with us today about this very important issue.
Yeah, my pleasure. Look forward to the discussion.
I want to just talk about the problem for a second. I want to bounce my thesis off you to get your take. My view is that if we all stand back and look at the situation in Canada over the last 25, 30 years, we've seen many examples where Liberal, Conservative, and NDP provincial governments have had opportunities to govern in this country, and we really haven't been able to see an example of any province really deliver exceptional health care that would be on par with, say, some of the better performing systems that we find in Europe in particular. Is that a fair conclusion, just based on where you sit and what you've observed over the past few decades?
I think there's some pockets of excellence, and I can think of Humber River Hospital, which has been a bit of a shining light for me to look at. It's a public hospital, but they've managed to figure out how to really efficiently do more surgeries within a surgical block, and so you do have
Hmm.
these real standouts of performance, high performance in localized areas. But as a system as a whole, it seems like uh, the provincial comparisons are how are we doing relative to the next guy? And as my finance minister likes to say, being the best is in that environment is like being the fastest skating kid on a slow team. You actually want to be
Yeah.
looking at places around the world that are providing optimal performance, and to do that, you do have to look to Europe, and that's how I'll be going to Europe later this month, Sweden in particular, to do that kind of investigation. I know you've been there and you've been doing some good work on that, but that's what we
Hmm.
want to do. We want to compare ourselves with excellence.
Yeah, and I think that's a good point. I mean, there certainly are pockets of excellence where you see different hospitals or facilities that are doing excellent jobs and patients that have wonderful experiences with the healthcare system. But I'm really thinking like on the whole, just we're not stacking up as a nation well, or even on a provincial level when it comes to these European models. And I started by noting that you're pursuing some major reforms in Alberta to try to bring the system closer to European models, and we'll get into that in a second. But I wonder about the people right now who are in the system. They're waiting for treatment, and they don't have time for health reform to take hold. They're waiting for maybe a year or two or whatever it is for like a hip or a knee operation. They're in chronic pain. In the past, you've mused about this idea of a healthcare guarantee, so that if a patient can't get their treatment within that recommended time frame, that you would compensate, or the government would compensate them for their cost to get it abroad. Is that something that you're considering at this stage, or is it still sort of the last time we spoke, you said you wanted to see your other reforms take hold first?
And there are a lot of steps that you get to before you get to that point. I mean, the first step that we had to take was making sure that our hospitals could be hospitals again. And so our whole refocusing was around that. I mean, the idea of everyone needing a primary care practitioner, that's one whole chunk of our
Hmm.
healthcare system. That's a different problem. The people who need mental health and addiction support, we're opening up recovery communities. We'll have 9 open by the end of this year so that people have a place to be in a bed and getting mental health and addiction treatment. That's a whole other arm of healthcare. Those who are in long-term care and are, periodically having health issues, but really need a more home-like environment, those folks are in our assisted living and social services. So we had to sort of separate those issues out so we could really focus on the problem that you identified, is how do we get our hospitals
Hmm.
functioning like hospitals again? So that when you show up in an emergency room, you have an efficient way of getting in, treated and released, or moved up to a higher floor, or you have an efficient way of getting your surgery, so it's within a medically recommended period of time. So those we had to separate those out. Now we have a focus on hospital and acute care services. But the other part is you need more than one service provider because that's the way that you
Mhm.
create the choice and options. And so over the last number of years, we've really increased the number of charter surgical facilities able to do a range of services. In fact, it's the only area that has been growing in the surgeries provided. So we do now about 330,000 surgeries in total, and somewhere around 70,000 of them are being done in charter surgical centers. So that was sort of a second reform that we needed to do. This next reform that we're doing is clearing the backlog. There are many types of surgeries that can be done either in a hospital environment or in a charter surgical environment. I'm talking about eyes and joints and some other types of surgeries. And now we're going to be doing almost like a voucher system where somebody who's been waiting on that list for a long time will be able to get a voucher to
Mhm.
receive that care at one of those service providers. And what we're hoping that will do is that will create more capacity as you're having the funding follow the patient. So we're rolling that over the
Mm.
next 3 years, and the next obvious application of that is to do exactly as you said, is that any person who finds themselves on a waiting list that is longer than medically recommended, a voucher would turn up in their house spending account, and then they would be able to seek out the specialist either here across Canada or even abroad to
Mm.
get the surgery and be reimbursed at that same rate. We're not quite there yet because I have always felt, let's build the capacity in Alberta first and let's try to get Alberta working first. And so that's why I said it's kind of a long way of answering it, but we had a number of pieces that we needed to put
Mm.
into place. But that most certainly would be on my mind as the next step. After we do this pilot on the 50,000 as clearance of the surgical backlog.
Okay, I want to get into what your government refers to as patient-focused funding. Other governments call it activity-based funding. We'll talk about that in a sec, but I want to ask you about something that we uncovered in Manitoba, which I think is an important policy change that's needed right across the country. Long story short, a patient named Debbie Fuster, she was told she needed heart surgery within 3 weeks. They put her on a waiting list. She died after waiting more than 2 months. And the family
Oh,
said, look, if we had known at the beginning that um, their mother would have had to wait so long, that her life would have been at risk, that they would have taken her abroad for
huh.
treatment so that they could have saved her life. And so we worked with them to come up with this idea of Debbie's Law, which would actually bring government in line with what government expects of the private sector. And that is to notify people of the wait time that the patient is facing, roughly for the surgery, but also the maximum recommended wait time. So the patients would know right off the hop if their life is at risk or not. And so when I say it brings it in line with the private sector, if a private company has an unsafe product, they have to notify customers, right? You think of the auto sector, or if a food distributor has distributed lettuce with E. coli, you have to get the word out, let everyone know, don't eat that lettuce. So is this something that your government would consider as having this built-in transparency requirement so that patients would know if they're what those wait times were for life-saving treatment?
Well, it is the first time that I'd heard about it described that way. I think that there always is a medically recommended window. I mean, the Fraser Institute always does their waiting list survey on the basis of what is the
Mhm.
medically recommended time and how long people are waiting. So I think it would be relatively easy to put that together. In the case you mentioned, my cardiac and cancer are very, very difficult because the potential for injury in transport, either out and back, the potential for complications, it would be far better to do those surgeries at home and prioritize them. And then the other surgeries that I was mentioning that can be done outside of hospital in a charter surgical center for knees, hips, shoulders, ankles, cataracts. If you can free up the hospital room so that you can make sure that no one ever has to wait longer than medically recommended for those uh, life affecting conditions. That would be the model that I think we want to move to is that we've got to have patients being treated in the right place. And you certainly have to have a
Mhm.
way to triage those who for whom a wait is not just going to be uncomfortable or painful, but deadly. So I think that there's some good tools that you can use. I mean, if you were to do as you described and you set that in place, then any patient who goes beyond that medically recommended period of time can then get elevated to a manager. And then the manager can say, "What are we going to do to prioritize this patient?" That's the kind of responsiveness that we need to get in this system, especially for cardiac and cancer, which can be really difficult to try to go abroad and get.
So Let's talk about these changes that you've alluded to. Patient-focused funding, you talked about sort of like a voucher model. Could you tell us a little bit about what that change looks like that your government is moving forward with?
Well, we're going to sort it out with the first 50,000 surgeries, and so part of what we did is we looked at the number of people who were on the medical backlog list, and then we did an assessment of how many of those patients are of such high acuity that they could only be done in hospital, and that's sort of a different track. If you have a lower level of acuity, I mean, by definition, if somebody has been placed on a long waiting list, some doctor has made a determination that they don't have sort of an emergent acute condition. They've made an assessment that it's an
Hmm.
elective procedure, that it can wait as opposed to an emergency procedure. And so we think that it's unacceptable for the person from the perspective of their quality of life, the disruption it's having in their daily activities, their ability to work. And so we identified that there may be as many as 50,000 that could be done in our charter surgical facilities. I mean, we'd love to have hospitals
Hmm.
arrange their scheduled surgery calendar so that they might be able to accommodate some of these. But that was what we were looking at: is how can we clear the backlog of these ones that have been waiting months or even years, and then see if we can learn something from that approach that we could apply more broadly. So that's what the patient focused funding 50,000 is going to look like. But more broadly, we want to move to a model where we have local decision making, local budgets, and we're paying those hospitals based on performance, based on their
Hmm.
utilization of their surgical suites, based on the number of patients that they're able to see and treat in their emergency departments, based on the number of patients that they're able to deliver surgeries for and release. It take because we've had a global budget system for a long time, which is essentially here's money, go treat patients, and there really aren't those accountability measures. It does take some time to get all of the new structures in place so that people understand, those who are making the decisions, that they're going to be rewarded based on the performance, and then it will be a position where everybody will want to improve performance. So that is the model that we are moving forward towards, and it takes time because you can imagine we've got 106 facilities that have pretty well been depleted of
Hmm.
site-based decision making at all. And so if you've got somebody who wasn't even allowed to order a bottle of bleach or change a light bulb without seeking somebody's permission, it takes a lot to build in the capacity to say yes, you can do those things and more, and then build the team around them so that they can manage budgets. So we're starting almost at zero capacity in some of our facilities, which is why it's going to take some hand holding to bring it up to a level. We've got to do it. You simply cannot centrally manage a
Yeah.
$34 billion healthcare system with a handful of people at the top trying to make every decision every single day. It doesn't work. You've got to allow for more flexibility and more site-based decision making.
I'll tell you, I've talked to people about how hospitals are typically funded in this country, and they are shocked. People have no idea that many provinces, and including Alberta right now, has this model where you just send hospitals a big check and then basically say, good luck this year. We hope you help lots of patients. Whereas, I compare it to like someone walking into a grocery store and giving the store $300 and saying, please give me lots of groceries. And people can't believe that that's how healthcare is funded. If I understand what you're saying correctly, um, the government is going to establish how much it will pay for different services. Like a knee operation might get, let's say, $20,000, and delivering a baby might be 10,000 or whatever. And then the providers know that that's how much they're going to receive if they provide those types of services. Is that generally the direction that your government is going in?
That would certainly be the case in some cases, but we also have to think about the type of beds that we fund as well, right? So somebody
Hmm.
being in a surgical bed for a day costs has a different staffing ratio, and it costs a different than somebody who's in a medicine bed for a day. So surgery is kind of short term. You've got pre-op, op, post-op. If everything goes fine, then you move on to discharge. Medicine, you can be there for a
Yeah.
long period of time. ICU is a different bed charge as well.
Mhm.
A transition bed for discharge, different level of care that you need as well. And somebody who should be waiting for a long-term care bed is also different staffing level. So what if we were to get a little more dynamic in how we pay for that? So that if you're in a medicine bed, we'll pay you 1,500. If that bed is full of, with a correct patient, $1,500 a day. Same with surgical. Maybe when you go to a discharge bed, maybe it goes down to $500 a day. Maybe when it's somebody waiting for long-term
Mhm.
care, it goes down to $200 per day. Because then what it would do is it would show the administrators, for me to be able to get the maximum value out of this bed, I've got to have the right patient in the bed. And then if we want to be able to treat more patients, then we've got to discharge in a timely way. So that's one
Yeah.
other area of dynamic pricing. Another one is, how do you fund your surgical suites? Because we have heard that sometimes surgical suite cancellations occur. And so then you've got a whole lineup of patients who are waiting for that surgical suite for one reason or another. The surgeon was unavailable, or the anesthesiologist was unavailable, or the nursing staff was unavailable. Well, what if you just didn't pay the hospital for the idle time? What if you only paid them if the
Mhm.
surgical suite was in operation and you had a lump sum that would cover all of the costs? Those are the kind of things that we're looking at. Is if we want our hospitals to deliver the outcomes, then we've got to pay them for the type of patients and the type of services that we want them to provide. What has occurred is, I think, some complacency, because the hospitals have said, well, a bed is a bed is a bed. It doesn't matter who's in it. What we discovered is that there were 1,700 patients who were categorized as alternative level of care, awaiting placement somewhere else. And when you think about it, we only have about 7 to 8,000 acute care beds in our system. If 1,700 of them are blocked with patients who shouldn't be there, that is 1,700 fewer patients with acute needs who can be treated on a day in, day out basis. So that's part of what
Mhm.
what we're moving towards. Is so and it is some transition. The way I think you do it, I've been giving some thought to this. How do you do the transition? Is that you can do a bit of a
Mhm.
shadow budget for the space of a year. So you can pay them for the first quarter the way you normally would on a global budget. And then you true up at the end of those 3 months and said, okay, we've looked at all these measures. If we had activity based funding on the basis of this, you would have to pay us back X amount of dollars, or you would have gotten X amount of dollars more. And then you can move that forward. And then
Mhm.
ultimately, once people begin to understand the model that you're paying them on, then you can do a live shift. I think we have to be very cautious about how we're doing it. We have to be very careful about how we're doing it. We don't want there to be any disruption in service at all, but we have to start moving into this kind of flexibility. Otherwise, we're going to be rewarding hospitals the way we have historically and not getting the improvement that we want. But I think that this issue of the global budget is at the heart of why it is we don't have more responsive systems all the way across the country.
Yeah. Well, I don't disagree with you. I mean, we've applauded your government as our think tank has, because it's the type of model that is used in countries with better performing universal systems. I mentioned that we've been to Sweden and France, Japan. They all have that. As a clarification, as an example, last year we were in Japan, and their government takes this approach where they figure out their fee schedule for different services. They post it, it's public, everyone knows they can enter the market and then receive those amounts for providing those services. Um, they don't have waiting lists, and they also don't worry if it's a government provider or a non-government, for-profit, whatever. It's not an ideological approach. Is that how your government is going to implement this policy shift, so that someone could open up a nonprofit clinic and then they could start to receive funding every time they provide, different services, or it could be for profit, or maybe it's another government entity that expands or whatever. Is that going to be the approach that you take?
In some cases, yeah, the complication that we have in inheriting this legacy system is the doctors paid separately from the rest of the hospital
Hmm.
services provided. So we have to figure out how to marry those two. So there isn't one comprehensive price that includes all of the surgical staff, the anesthesiologist, and the doctor, and the facility fee, and the orthopedic implants There isn't one total price in hospital, but there is in charter surgical
Right.
centers, and we do it exactly as you described. It took some time. We had a number of different contracts that were written, and I think we've landed on a contract that is reasonably fair in that it pays less on certain procedures that than we would in a public hospital, but they also have less acuity as well, and so they don't have the really complex patients. And then we have a certain number of surgeries that we're prepared to pay for, and they're allowed to then take that guarantee to the bank in order to get the financing they need to run their operations. And so that's we just did a request for expression of interest in December, and we got, I believe, 50 submissions. We just said, what do you think you can do? Tell us how many surgeries you can do, of what type, and what would you think would be a reasonable price to pay for that. And we're working through them to see if we can establish some contracts on that basis. So there's a price discovery that we have to go through, because our market's going to be different than the American market. It's going to be different
Mhm.
than the European market. So there isn't really a price that we can pull off the shelf. Some of it we have to offer it up into the market and see who's willing to build the facilities, because this is, again, fresh build, new capital of being invested, new equipment having to be
Mhm.
purchased, and so our pricing might be a little bit more dynamic as we sort that out. But that's the combination. And then once we learn more from what our charter surgical facilities are able to do, then we can start getting more transparency about how we fund our publicly funded hospitals on a similar basis to get the same kind of incentives in place.
I want to switch gears and talk about what the other major change, which is known as dual practice for Jane and John Viewer, who's wondering how it affects them. It basically means that someone in Alberta will be able to pay for surgery in the province instead of being forced to leave the province. Is that essentially the change that is happening that your government's making?
Well, let me tell you a couple of things that we discovered. We already really do have dual
Hmm.
practice. There are a number of different entities that can get their surgeons into a hospital and pay a facility fee, and then it's billed out separately. And it's the RCMP, it's
Yeah.
Workers' Compensation Board, and I believe it's also sort of our correction system as well. So we already have a model for that. But what we also discovered is that there are some surgical centers that if they bring in a visiting surgeon, because that surgeon does not bill us, they're able to do the surgery here. And then we also discovered that there are some facilities that might have a surgical facility outside of the province, and they can fly the patient and the doctor to that facility, and then they can pay out of pocket
Yeah.
there. And we just thought, why are we going through all of these hoops? Why don't we just, if this is what people want, if they want the option of being able to wait a little bit longer and get their service 100% publicly funded, preserve that choice. That's what our public
Hmm.
healthcare guarantee is. No one will have to pay out of pocket. But if somebody's made the calculation that they don't want to wait and they do want to pay out of pocket, then let them have that choice as well without a whole bunch of additional hoops to jump through. The only thing that we're going to ask is that doctors who are currently working a couple of days a week in the operating rooms in the public system, keep on working a couple of days a week, and then the rest of the time is yours. Because what we have found
Hmm.
is that in order to control costs, administrators often ration operating room time. So our
Yeah.
surgeons, we have been told, would like to do their practice more than they are allowed to in the public system. So we're flipping it and saying, okay, instead of saying, okay, you only get 2 days a week of operating room time, we're saying, okay, you must give us 2 days a week of operating room time, and then you can see private patients the rest of the time. And we believe that that will allow us to preserve the 330,000 surgeries we're currently paying for each year, but also provide maybe a few hundred, maybe a few thousand additional surgeries that would allow for us to speed up the queue. Because that's the way to look at it too, is that if somebody chooses to take themselves out of the queue, they get their surgery faster, but the next person in line gets it faster too.
Hmm.
And so we that's how we're going to be trying to increase capacity and create more opportunities for surgeons to work in our province.
I'll share an anecdote for viewers. You might be familiar with the story too. Jeff Cushell, patient from just outside of Edmonton, we profiled his story. Long story short, he had severe back problems. It was causing him a lot of emotional issues and that too. So he decided he didn't want to wait a year for his back surgery, looked all across Canada, And the only clinic that provided the type of surgery that he needed privately was in Calgary. And he thought, this is
Hmm.
fantastic. He called the clinic, he was all excited. And then they said, wait a second, sir, where do you live? And he said, I'm in Edmonton. I can get down there next week if you can get me in. And they said, no, we're not allowed to operate on you because you're an Albertan. So clinic in Calgary could literally treat people from all over the world except for someone from Alberta. So
Anyone on the
you know,
planet, anyone from any other province, but not
yeah,
in Alberta. And that's what we looked at. We just said,
yeah,
does that really make sense? Or is there another way that we can preserve our public health guarantee but still give that option? And that's what dual
yeah.
practice is for.
I, uh, I think it makes a lot of sense to remove that red tape. It doesn't make sense in my mind to force people who are in pain to fly or travel outside of their province to get treatment. Like, why would we do this to people that are suffering? I want to ask you though,
And Colin,
what
and
has been
beyond that too,
Ottawa's?
beyond that too, if you when you think about having major surgery, the last place
Hmm.
you want to be is flying in a plane out and back.
Oh yeah,
And if
yeah,
you're recovering in a hotel room until you're well enough to recover. If you are able to get that surgery here, you can go home and convalesce. And if you have some issues that the doctor needs to see you, they're right there. So it's actually better medicine for us to make sure that more people are able to be treated closer to home as well.
oh for sure. I want to ask you, what has been Ottawa's reaction to this change that you're moving forward with? In the past, they've been very oppositional, at least under the Trudeau government, to any notion that people could be allowed to pay privately if they don't want to use the public system. So what's their reaction been to your changes?
Well, you have to remember, doctors can opt out of the system, and 800 of
Mm-hmm.
them have in Quebec, and we were very worried about
Mm-hmm.
that because what we're worried we don't want to lose that expertise, and so instead of having here's your choice, you're either 100% private or 100% public, we said could we have doctors do both so that they can have patients in both systems as long as we've got some good reporting structures and we're making sure that our public system is taken care of first. And so we've told the federal government we're moving towards a European style system. We've got a prime minister who's familiar with Europe because he spent many years there. And so at the
Yeah.
moment, I think they're allowing us a little bit of latitude and we just have to demonstrate that it works. And I think we will.
Okay. Listen, this has been fascinating. We'll look forward to chatting with you for part two.
Thanks, Colin.